Hello everyone and welcome to this evening's Facebook Live. I'm Claire Morris, Clinical Manager at Wound Care People. Just to remind you, we're broadcasting live from our own homes, so if we do have any problems, please bear with us. Tonight's session is Continence Promotion in Dementia Care. Is this overlooked? And our speaker tonight is Zena Aldridge, Admiral Nurse Research Fellow for Dementia UK. A big thank you to Essity for their support this evening. And just to let you know, certificates will be available at the end of the presentation. And you can send in any questions by commenting on the video. So without further ado, I shall hand over to Zena. Thank you, Zena.
Thanks, Claire, and thanks everyone for tuning in this evening. I'm really grateful to be able to share this session with you. Just to clarify that the learning objectives for today are hoping to challenge misconceptions about incontinence and dementia, and explore some of the practice examples and practical tips that you may be able to advocate to improve continence management in people with dementia, and begin to consider what the impact of poor continence management might be for people with dementia and their family carers, not just people with dementia themselves alone. So I'm going to start with some myth busting. We've got a huge amount of myths and misconceptions about continence management in dementia. So it's considered by some that urinary continence is a symptom of dementia. It's inevitable. Secondly, there is nothing you can do if someone with dementia experiences incontinence is another myth that I frequently hear. Incontinence for people with advanced dementia in nursing homes is inevitable. And again, we'll challenge that this evening as well. And if a person with dementia is wearing a pad, then they won't mind being incontinent and they don't need to use the toilet. And finally, the myth that family carers will know how to access support and advice. We'll address them one by one. So the first myth I'm going to look at is the urinary incontinence is a symptom of dementia. What we know is that people with dementia often experience incontinence, and it's likely to be concurrent with dementia as opposed to a symptom of that, especially particularly in the earlier stages. You also find that people with dementia have multiple comorbidities. A good 90% of people with dementia have at least one comorbid condition. And as they get older, the incidence and prevalence of comorbid conditions increases. And of course, we also then get intercurrent conditions such as urinary tract infections and things like that that can all place extra issues on continence management for people with dementia. We do know, of course, that as dementia progresses and people get into the more advanced and end stages of dementia, they are far more at risk of developing incontinence. But it still doesn't mean there's nothing that we can do to support the management of the continence issues, but also maintain their dignity and well-being. We'll touch on that a little bit later as well. And as I said, dementia rarely travels alone. And we also not only need to think about the comorbid conditions that people with dementia might experience, but also the multiple medications that they are on. Similarly, some of the medications that we prescribe for overactive bladders and things like that can then cause further cognitive impairment and decline. So we need to think about the cholinesterase burden as well on any medication that we are considering, because the two go hand in hand, and looking at the cause and effect and weighing up the risks and benefits is really, really important in managing these kind of issues for people with dementia. The second myth is there is nothing you can do if someone with dementia is incontinent. Now, this is a very, very complex thing. Again, because we often look at the very mechanical reasons or physical reasons for incontinence, we rule out some of the other issues that might be causing the problems in managing someone's continence needs. So I've already mentioned medication, and interestingly, we still see that people's diuretics aren't reviewed and other medication that can cause problems. Even pain management, because of course, if someone is in pain, it may then impact on their mobility and affect them being able to go to the toilet, or actually feeling that they want to push themselves to go to the toilet because it's going to be too painful. It's often considered that, the main issue with dementia incontinence is around memory, but dementia affects the person in so many other different ways. So memory is only a very, very small part of the cognitive impairment that someone with dementia experiences. They can have visual disturbances, issues with visual spatial awareness, processing and completing tasks. So all of those things have to fit in. So it's not just a case of someone forgetting to go to the toilet and needing prompting. It's far more complex than that. So, for example, people might not recognize the environment anymore. They might not recognize the physical environment. So even at home, sometimes it's worth putting a sign on the toilet door, for example, to remind that person that that's where they need to go to use the toilet. Similarly, if they lose the ability to recognize words, they may then appreciate a picture of a toilet on that sign, so that it then jolts their memory and enables them to consider that that's where they need to go for the toilet. Often they have trouble with differentiating colours and things like that. That can be an issue, and visual disturbances. So we often recommend that a different coloured toilet seat can really help someone who's got dementia, because they can then look into a bathroom and see either a dark black toilet seat or a coloured one. I know in lots of environments they use lovely primary coloured ones, so they stand out. Because if you can imagine, some of our bathrooms are very sort of sterile, insipid colours, so trying to disseminate where a white toilet is against a beige or grey floor and grey walls can be really, really difficult if someone's got that visual impairment. Similarly, one of the things that can happen is bathroom mirrors. People sort of raise their eyebrows when I say this, but one of the problems that people can have is, as their memory does deteriorate, they lose their short-term memory. And so when they look in the mirror, they may not recognize the person they are now. They may be looking to see the reflection of someone who's 20, 30, 40 years younger than them. So you can really imagine, if you go into the bathroom, either alone or with someone supporting you, if you look up into the mirror and you see an older person who you don't recognize looking down at you while you're trying to, do your ablutions, that can be really distressing for people. So they may avoid the bathroom because of the fact they think they're seeing someone else watching them. And that can cause real tensions, because people are frightened, and it can become quite an issue in terms of their behaviour. They can become distressed and anxious in those sorts of environments. So it's really important to think about. Similarly, even floorings can be difficult in even domestic homes or in clinical areas. For people with dementia, again, a shiny floor may look like water. And of course, if you're frightened, you might not get out of your chair to go to the bathroom because you're scared you might actually slip or go into the water. And also, rugs can sometimes feel like big black holes that they might slip into. So, these aren't normal things that we would consider in continence assessments, but they're really important to think about in terms of people with dementia managing their situation in a way that enables them to remain as independent as possible. Dexterity is also something that can be affected. So even things like thinking about clothing, easy access clothing, not multiple buttons and difficult complex dresses and outfits to get out of, that can make a real difference as well. Because obviously, again, if they're not got the dexterity there, that can be problematic. But really and truly, it's about trying to get to know how that dementia affects that individual person, because dementia is an umbrella term for such a broad range of conditions that the symptoms are very, very different. And as a result, we need to really understand what type of dementia someone has, to understand what symptoms they might have, and then be able to help them to manage that. And of course, word finding is another issue. So people may not be able to say the words for "I want to go to the bathroom" or "I need the toilet," those sorts of things. So they might get frustrated, and then because they can't communicate and maybe need assistance, they're not able to go to the toilet. So I think there's so many things that we can do to support people with dementia to improve their continence above and beyond just prompting them or encouraging people to prompt. So as I said, prompting is part of that. Another thing is about reassurance and communication, and thinking about what language does that person use? Because people perhaps have different keywords. They might have words by association that mean the same sort of thing. It's about that reassurance and communication that just because they've been incontinent once, it doesn't necessarily mean it's going to happen again, and trying to consider what might have happened in that situation at that time. nutrition and hydration and the links around that are really, really not all, they're often not known by older people in general. But for people with dementia, again, they might forget to eat and drink perhaps as frequently as they should. The carers might think, well, actually, I better not give them too much to drink, because of course they might then be incontinent, and they're more susceptible to UTIs, etc., and constipation. One of the things we know for people with dementia is that they are far more susceptible to developing a delirium if they get a UTI. They're more likely to be admitted to hospital. And sadly, what we know about hospital for people with dementia is if they are admitted to hospital, their morbidity and mortality risks are far greater than the general population of the same age without dementia. So what we want to do is look very much around prevention, certainly around skin integrity as well. People don't always know how to manage the skin integrity issues. And often it is about being really creative and thinking about outside the box. So stepping away from some of our sort of traditional methods and solutions that we might employ, and thinking about individuals themselves. And when I say that, I sort of say it with a smile on my face, because I'm thinking of a gentleman, Jack, who is a gentleman that I had some involvement with, him and his wife, for some time. He was on my caseload, and Jack was a very rural young man. We got to have some very entertaining chats over the time we got to know each other. We always used to have a bit of a laugh and joke. And as time went on, his continence, or his incontinence, urinary incontinence at night, became a real issue for both him and his wife. He would often wake up in the night quite disorientated. He would want to pass urine. He wasn't comfortable using a commode or a urine bottle. His mobility and his perception at night wasn't great, so he wouldn't necessarily find himself going to the toilet. So he'd either pass urine near to the bedroom, near to the bed, or perhaps in the corner. And that was really, really distressing for his wife for multiple reasons, not just the fact that he was urinating in other places, but also that then has the impact of more cleaning, and she's already caring for him in a much greater way than a normal sort of husband-wife relationship because of his dementia. So we tried to look around strategies. That the commode wasn't working, and from previous conversations with Jack, I knew that he grew up on a farm with several siblings, and he had spoken about the outdoors privy several times in the past. And when I asked him about what did you used to do at night, I thought this might be a way around it. He goes, "Oh, I used to use a jerry." And a jerry was his language for a chamber pot that used to sit under his bed to pass urine in. So I said to his wife, well, let's try that. Let's try a chamber pot, because it's familiar to him. The commode and the urine bottle, he just couldn't kind of get to grips with. And again, he did get more confused at night. So that was something we needed to consider. Sure enough, we got his jerry. We told him it was there, and he used it. And he used it fairly proficiently, which made a huge, huge difference in so many ways. Because, of course, it's not just about the practical issues. It's also about what that then means for that person with dementia and their family carer. It meant that Jack and his wife could remain in the same bed together and share some intimate moments, which that was really important to them. They were a very affectionate couple. And of course, continence can be something that prevents people from sharing a bed. And there are so many losses attached to dementia for multiple reasons in a relationship. So being able to retain those aspects of relationship was really, really key and really, really important for Jack and his wife. And he was an absolute joy. And I think that's why person-centered care really reflects getting to know the person and getting to know what's important to them, can sometimes give us those little snippets of hope that we can just try something a little bit different. The third myth is about incontinence for people with advanced dementia in nursing homes being inevitable. I want to challenge that and let's think perhaps slightly differently about that. Although we know the risks are greater, I've seen cases where actually that's not the case. And I want to talk to you about Gladys. Gladys was a 93-year-old lady with quite advanced dementia who was in a nursing home. She'd been there for some time following an admission to hospital. She was receiving one-to-one specialist support with continuing healthcare funding because she's deemed to be quite challenging in her behaviour. And I was asked to go and review her case because there was a concern about the cost of this package of care and whether it was what she needed or needed to be somewhere else. So I went off to see Gladys, and I expected to see someone, looking quite frightening. And what I saw was a 4 to 5 stone lady curled up in the fetal position in her bed, and her son was there. And not long after I'd entered the room, she said, "I want a wee, I want a wee." At which point the carer said, "You've got a pad on." If you can hear my eyes roll at that point, I was quite shocked that that was so overtly said in front of both myself and her son. And I challenged that, and I said, "So, but she's just said she wants a wee. Why don't you try her on the commode?" They said, "Oh, we can't do that. She's really aggressive." And I said, "But do you think she might be aggressive because she's in pain?" Because this lady clearly had arthritis. You could see her joints were really, really quite swollen and distorted. She'd got scoliosis of the spine, so she was really curved over. And of course, she was quite contracted. And if you think about being rigid and your muscles being rigid all the time in bed, that's got to be painful. If you just sit there for a moment and try and clench your muscles, after a while that gets quite wearing. But her muscles are like that all the time. So of course, every time someone's going to move those muscles, it's incredibly painful. So I asked to see her pain, her drug chart, and it turned out she was prescribed Oromorph, but hadn't been having it because they said, "Oh, she doesn't know she's in pain. She refuses it." So it was really quite difficult for me to maintain my cool at that point because obviously, this lady did have word finding difficulties and was quite cognitively impaired. But I gave her a small dose of Oromorph. She clearly didn't like the taste because, I don't know if any of you have ever had to have the misfortune of being prescribed Oromorph. It's very, very bitter in taste. So it's not pleasant. So her face really shriveled up. I spoke to her and said, "Gladys, let's give that 10 minutes to work and then we're going to get you out onto the toilet." And believe it or not, 10 minutes later, we were able to put her in the hoist. I held her hands and spoke to her while the carer was supporting me to move her. She got onto the commode, and as soon as her bottom hit the commode, she passed urine. Sadly, it was a vile colour, and clearly this lady was continent. She knew that when she wanted to pass urine, and what she was doing was obviously going into spasm and contracting because she was holding on as tightly as she could to maintain her dignity. I think that there's this thing that people think, well, once you've got dementia in your advanced stages, you don't know and you don't care. Well, clearly in this case, she did care. So what we did for Gladys was that she was prescribed a pain patch. I recommended a pain patch with a GP. She was also given some antibiotics because this was someone who'd had a sepsis from a urine infection previously. So we wanted to prevent her going into hospital. And believe it or not, 2 or 3 weeks later, this was a lady who was on multiple antipsychotics, receiving a one-to-one package of support. She actually didn't need the one-to-one support any longer. She didn't need the antipsychotic medication. She needed pain relief, and she needed people to respond to her continence needs. And she was able to maintain her dignity. Of course, it was intermittent, but we went for, the fact that 5 times out of 10, she was able to maintain her continence. And for me, that was a real success. And not only does it save money to the wider health and social care system, but it maintains her dignity and improves her quality of life. And I think, again, that's one of my key take-home messages today is, when we think about continence management, we need to think about the implications of that. Because going back to Jack, one of the things that his wife had said to me was, if he becomes completely incontinent, I'm not going to be able to look after him at home. That's the tipping point. And for a lot of carers, that is the tipping point. That means they want the person they care for to have to go into care because they don't know how to manage it. So, what we do in terms of managing that can have such a big ripple effect, not only for that family, but for the wider health and social care systems. So people could end up going to care prematurely when we could have kept them at home for longer. I think, again, think about distress behaviours with incontinence. I think there are a lot of people who struggle with word finding, or they are unable the toilet, and so they become really, really distressed. And if you think about, if you feel anxious at any time, how does that manifest itself? You know, you kind of get red, some people get quite irritable, you know, all those things about feeling anxious and vulnerable can come across as frustration and an aggression, where actually it's more about fear and feeling compromised in their dignity. And there can't be a more horrible feeling than knowing you're going to be incontinent and being unable to ask for the support to manage that. So often you'll find a real link with distress behaviours and continence issues. And I would always say to you, if you are working with families, explore, is that person in pain? Are they having issues with continence? You know, when are they opening their bowels? Because sometimes it's as simple as that, and that person just needs that support to meet their basic needs and maintain their dignity. One of the other things we're going to look at is now myth 4, which is if a person with dementia is wearing a pad, they don't mind being incontinent and they don't need to use the toilet. Well, as we saw in our previous case study, that clearly wasn't the case. And certainly for people in the early stages, that certainly is the case. And that wasn't the case with Madeline, who was a 72-year-old lady who I supported both her and her daughter in the early stages of the COVID pandemic. I went back to work with colleagues clinically for the first 3 months in the community. And Madeline had been living alone in sort of housing with care, sheltered accommodation start arrangement. But her daughter was really mindful once the COVID lockdown hit, that she was concerned that her mum wouldn't be able to go out or perhaps maintain her safety going out and get support from other organisations. So they had a conversation and Madeline moved in with her daughter. Now, her daughter was aware that she had been having issues with her continence, because she used to do her washing and sometimes she'd find soiled underwear or clothing. She'd often find things that Madeline had tried to hand wash and sort of secrete out of the way because she was embarrassed by her issues. But until she moved in her daughter, she wasn't really aware of how difficult this was for her mum. And so what manifests itself was the fact that Madeline was having to go to the toilet sort of every 15 minutes. Because she was having these issues of incontinence. So she was getting really anxious about being incontinent again. So she'd keep going to the toilet, but sometimes she wouldn't be able to get there in time. It meant that she couldn't go out and about. She didn't want to go out for walks. She certainly didn't want to go in the car with her daughter anywhere, because she was really worried about whether or not she'd be incontinent in the car. And certainly at periods during lockdown, one of the big issues, of course, has been the lack of outside, public toilets available. So even if she could persuade Madeline to get in the car, she wouldn't be able to persuade her to go anywhere, because she'd know that there probably wasn't a toilet available when she got there. They didn't know about radar keys. And of course, often, again, they're associated people with very obvious physical disabilities rather than the hidden disabilities. So again, there was all these kind of barriers in their way. So Madeline was obviously quite embarrassed by it. She tried to hide it. She had been seen by the Continence service about 18 months, 2 years previously. But it had really, really rapidly, it got worse over those last couple of years. And she didn't know what to do. She didn't know how to ask for help. I asked to see her medication. As it was, she was on 60 milligrams of furosemide, which was a huge dose for a lady who wasn't particularly big, which was warranted when it was first prescribed but hadn't been reviewed. So, of course, that was having a really significant effect on her frequency. But what was really standing about Madeline was the effect this was having on her mood. This was a lady who, her daughter showed me pictures of her. She always used to look immaculately dressed, put her makeup on her hair, and you could see she was really quite low in mood. She was becoming more withdrawn and socially isolated. So this was having a real big impact on her life. So we spoke to the GP, we got those diuretics reduced. We tried to look at, all the practical aspects of when she should drink, cutting down caffeine, all those kind of things. And within a couple of weeks, Madeline, you could start to see her sort of almost open up. She was like a little flower that was opening up. And it was because she was being able to go every hour to every hour and a half to the bathroom. Now, for me, that still feels a lot. But obviously, for someone who's been going every 15 minutes, this was actually quite life-changing for her. So she was having less episodes of incontinence. So again, her dignity was, improved. She felt much more confident in managing the situation. And it enabled her to feel safe to go out for a period of time. And I think on one evening they'd driven down to the coast for a bag of chips and things like that. So this is not just about us thinking about the functional aspects of managing continence care. It's so much bigger than that. The continence team were great. I re-referred her back to them, and they got better pads for her to use, which meant that she wasn't having to change them. She wasn't getting a sore. So, unfortunately, neither of them would probably have sought help unless it kind of came out as part of another assessment. So it's really important that we kind of really encourage people to ask about continence, because there's still a stigma attached to it. And there is this assumption that it's just part of dementia, it's normal, it's to be expected. But clearly it can have a significant effect on people who are living with the condition. I think the other issue is now myth 5, thinking about family carers. Will they know how to access support and advice? I'm really, really sorry to say that I would love to say that they do, but unfortunately, most people, when they are diagnosed with dementia, if they are diagnosed with dementia, because we know that less than 2/3 of people in the UK get a diagnosis of dementia, very few get post-diagnostic support that is with them through the duration of the progression of the disease. Now, I don't know any other life-limiting condition where we would do that. Most people get an annual review at the GPs, but that's very much around sort of the physical basic health checks, how you're doing, that kind of thing. It's not what I would consider a holistic assessment of what their potential needs might be. So often people are given that diagnosis, and if there are no medication options to support them, they are diagnosed at the point they're discharged at the point they're diagnosed, which means they don't tend to come back into services until they hit a crisis point. So there's so many lost opportunities in looking at some of these situations and making them better. We also look at people in singular disease processes. So we'll have scenarios where people will go to the GPs for heart failure checkup, dementia checkup, COPD checkup. But very rarely are all of those things pulled together, and we look at that whole person and say, how might this impact on them? What might some of the issues be for them? And asking them about, are they struggling with things like incontinence? Have they become issues? So families do think this is normal. They just kind of think it's supposed to be expected. They're embarrassed. They don't know where to go. Dementia is still seen by some as a mental health problem because people are diagnosed in mental health. But dementia is a progressive or set of progressive neurological or neurodegenerative conditions. So it's not a mental health problem. And with it comes some of the other complexities that we see in those who live with the condition. And again, if you don't have that support, how do you know what's normal? If you've kind of seen different articles, or you've gone on Dr. Google and they've said, well, incontinence and dementia, there's nothing you can do about it, and you've not looked at the right support, how do you know where to go? It is a taboo subject. It's something that's really, really personal. People are still embarrassed, particularly the older generation. It's something, again, that, they wouldn't necessarily volunteer. You would have to dig a bit deeper and really ask them about, what's going on? Are there issues? And even then, some of them really struggle to be honest with you. And of course, it has such significant impacts on, as we've already mentioned, their health and well-being, their dignity, managing their personal care needs. And a lot of spousal carers particularly really struggle with trying to provide personal care or prompts within in a spousal relationship for personal hygiene, because that can often be a real flashpoint. So of course, when you're living with someone 24 hours a day, 7 days a week, you don't really want to keep pushing that all the time, because what you want to do is try and have a quiet life. But of course, these things escalate. We see them escalating. And it is about that dignity and the privacy, and maintaining someone's independence for as long as possible. So again, some of those things we talked about earlier in terms of changing the environment, and how we perhaps support people to use the toilet independently, they can all have a really significant and positive impact on not just the person with dementia, but their family carers. You if I literally can't, say enough times, if I had £1 for every family carer who said, when my loved one's going to be, when they become incontinent, I don't think I can do this anymore. And it's like they've drawn a line in the sand. So the minute that person becomes incontinent, they're then starting to wrangle with those decisions in their minds about whether they should put that person in care. There's lots of guilt around that, and people will always question their decisions. So if we can support them to ameliorate some of these tipping points, if you like, to a point where they can actually make an informed decision later down the line, I think that's got to be incredibly positive. People don't know where to go. Continence is a thing where they don't always feel it's appropriate to go to the doctors because they don't feel ill as such. And again, not knowing what it is they're asking for, what can be done. All the aids that we see, yes, they are becoming much more widely available in stores and things like that, so they are more accessible. But people still don't necessarily know what to use. They may not think about the precautionary bedding they can use, all of those things which can really make a difference. I can't imagine being 85 and having to look after my spouse and do extra washing and perhaps scrub the carpets and all those things when you're already having to do everything else because that person's unable to do so. So these are really, really critical parts of care that we provide for people with dementia. The impact of it is significant. As I said, being unable to access appropriate support and guidance about how to manage continence, all of these things that we've talked about over the last half hour, they're all quite simple to engage people with, but sadly, if you don't know what you don't know, I guess. And again, that means that they don't get the practical advice, they don't get the appropriate aids and the strategies to reduce those episodes of continence. And it's not the saying that we can completely get rid of the episodes, but we can certainly reduce it. And of course, as I've said, it has a huge impact on urinary tract, the risk of urinary tract infections and damage to skin integrity. There is that negative emotional psychological impact on family carers because of the intimacy, because of the guilt and the inability to cope with it. And seeing the person before them struggling with that, those episodes where there is conflict and there's behavioural changes, it makes it really, really difficult. There's also a financial impact because, of course, if people don't get the right assessments, they go out and buy perhaps aids and pads and things like that, which might not be fit for purpose for that particular individual. And of course, then there's all the other added consequences of damage from inappropriate urination and things like that. So, there's all those elements. And it's fatiguing, if you're waking up in the night, if you're feeling that actually being that person's likely to get up and inappropriately use a toilet at night. People sleep with one ear open, and so they get more and more exhausted. And as I said, that can lead to the hospitalisation and premature admission to 24-hour care, which is something we really want to avoid if possible. So it's about thinking about the assessment for both the family and the person with dementia, and thinking about the strategies that we can employ. And one of the things I want to talk about you is another couple that I've met, because I think reviewing protocols is something that we might all be able to do something about. I want to talk to you about Bill and Sheila. Bill and Sheila were quite an inspirational couple. I've been working with them for many years. Bill was caring for Sheila. She had early onset frontal lobe dementia, so she had a lot of changes in her behaviour and her language skills. He was one of the most wonderful gentlemen in terms of a family carer. He used to make sure she was out and about and entertained. He would cook from scratch for her. He would deal with her personal care, and he would manage her incontinence. Now, she'd been doubly incontinent for some time. And initially, it wasn't too much of a management issue. You know, she'd be quite compliant with the aids and with his personal care. But as time went on, that became more difficult for him. And what she was doing was removing the pads. She was secreting them elsewhere. You know, it was just getting more and more problematic. But he was really keen that he remained the sole carer, and he didn't really want 24-hour caring. So they'd been assessed by the Continence service. Sheila had pull-up pants for night, but she had pad and pants for during the day. And he said, well, can I not have the pull-ups for all 24-hour use? Because she keeps them on. She recognises them. They feel like a normal pair of underwear, so she doesn't see them as a foreign object. And she uses them appropriately. She pulls them up and down, and she's not bothered by them at all. And it was said, no, we can't do that. You know, we're only allowed to prescribe so many a day. So he was saying, well, hang on a minute. You know, if I stop caring for her, it's going to cost a lot more money. So, you know, what can I do to change this? So he was a very, very resilient man. He was very intelligent and articulate. And he said, no, I'm going to challenge this, because all they're doing is looking at Sheila. They're not seeing the impact on me and what this means to me and her as a couple. And actually, I want to challenge this. So we took that challenge to our local CCG at the time. And I'd have to say, I didn't think we'd get much in the way of a positive response. But actually, he was so articulate in the way he conveyed himself and talked about the risks and benefits and the cost to the wider system if he no longer cared for her, that he then decided that they actually listened and looked at the algorithm that they constantly use, because the incontinence team as well kind of agreed with him, but they had a kind of ceiling that they could prescribe to, and it was beyond what they were able to prescribe. So it was agreed, with support from the quality team within that CCG, that the algorithm would be changed so that the continence assessors had a degree of clinical flexibility. If they felt that it was not just the person with dementia but the family carer, it would help them manage the incontinence better, they could use their discretion and prescribe the pull-up pads for the whole 24-hour period. And for them, it was really life-changing, because it made such a difference. You know, she even trying to, if you having trouble with dexterity as much as not recognising objects, putting a pad and pants up on your own independently is quite difficult, but it's also quite difficult for an older carer to be able to manage to do that. And of course, if someone sees us as alien, it then means that their continence isn't managed as well. So that was a real success. And I have to say the continence team were really, really grateful, because, as I said, it gave them that clinical flexibility to be able to prescribe pull-up pants over the 24-hour period for those that they felt it appropriate for. And I think the familiarity of not obviously the skin integrity is protected as a result, but the familiarity of pulling up and pulling something down that reminds you of normal underwear is something that is really beneficial for people with dementia, because it doesn't feel alien and it feels more dignified. And we're certainly seeing all these products being made beautiful for younger women. Why do not older women and older men feel that they need to have that security and comfort and feeling that they are wearing something that feels quite comfortable to them? And certainly here we've seen that they score higher in satisfaction for people, carers of people with dementia, than those with a pad and nets. And I think for obvious reasons that we've just discussed, the ease of use, the familiarity, and often if people are far more concordant with their use, it makes life far more comfortable for both concerned. And I think what I'd love to see us do is move away from seeing continence as issue in isolation. People with dementia are complex, their families are complex, their needs are complex. And we need to start thinking about the whole system as a whole. Continence is such a big part of what what can be the barriers to providing care at home. They can be a huge cause of stress and crisis for families. And as you said, even with the case of Madeline, the impact on their well-being is so significant. It's just often not communicated in the same way that perhaps someone who's younger or less cognitively impaired can do. And I think if we could just stop a couple of hospital admissions here and there, preventing people going into hospital and that spiral that could happen after that, I think that would be a job really well done. But I appreciate it's not as simple as I'm kind of painting it, but I think there are people like yourselves who can really make a difference in making these changes to be able to, get a better outcome for people with dementia and their family carers. So to conclude with, I apologise, I feel like I've given you a whistle-stop tour of some of the do's and don'ts and mights and maybes, but I think it's about managing incontinence for people with dementia and their family carers, seeing that as a vital component of their care, and not a bolt-on and not a something that's going to be inevitable. It's possible, but there are ways that we can use it. Using the growing evidence base, not just about incontinence, but its links to the wider management of dementia and well-being for people with dementia and their families, I think can really start to shift practice and get us to think differently. And I would say, never assume you can't make a difference, because you absolutely can. And whether that be from your direct actions or whether it be from empowering people with dementia and their family carers, such as the case of Bill, I think that's something that is good to be able to let them have a voice, and be able to state their case and tell people what it is they need, rather than us telling them what they need. There's some useful resources that you might find there from Alzheimer's Europe. Dementia UK does some really nice leaflets that are quite user-friendly, either for clinicians, but actually for families as well. So they're free to download, or you can order hard copies as well to take out and share those with people that you might be coming into contact with, because it gives some useful hints and tips to family carers on how they might be able to manage incontinence going forward. Thank you so much for listening, and I look forward to your questions shortly. Thank you.
Thank you so much, Zena. That was absolutely fantastic. Thank you. Just to let our audience know, you can join us again on the 10th of March to explore the complexities of continence management in dementia care. And this event will be presented by Professor Graham Stokes, who's Director of Memory Care at HC1. So for further information on Tenor products, including Tenor Pants, and to obtain a continence and dementia care digital resource pack containing a summary of both presentations and any supporting evidence, please contact your local Essity representative or email hcmarketing@essity.com. So we're now going to move over to our real-time question and answer session. And remember, you can take part still at any time by commenting on the video. So let's move over to our first question. Okay, so the first question is there a specific assessment pathway or document that you would encourage to be used when assessing the continence needs of an individual in dementia care?
I'd love to be able to say yes. Sadly, no, because it is such an overlooked area. And I think those that are more familiar with dementia care practice will look at some of the issues that we've talked about this evening and factor those into a continence assessment. But to my understanding, there's not a fit-for-purpose tool that does that. So it's about kind of merging two evidence bases, if you like. It's kind of what we know about assessing incontinence and managing it in a very practical way, but then incorporating some of these tips about how we might slightly look at that differently to meet the needs of people with dementia. And I've really just touched the surface really tonight. There are so many other elements, and I think it's just kind of, once you start to look at what the issues are, you can start to think about how you might address them, because it really will be very individual to each person that you see. No two people are the same.
Okay. Question 2 is from Lindsay. Have you noticed a difference in communication since face masks have become mandatory?
Absolutely. It's a real problem. I mean, one of the issues is obviously about word finding and communication in dementia per se, but often a lot of people with dementia also have hearing and sight loss and things like that as well. So it is really an issue. And I think you're right, it's a real barrier sometimes to engaging in communication. For people who are in the more advanced stages, of course, sometimes they don't understand why they've got to wear a face mask, or why professionals have got to wear a face mask. And of course, if you're having difficulties with your speech, anything that kind of muffles that and makes it more, or makes you less coherent, really is a barrier to intervention. So absolutely, I think, like many professionals and families affected by this at the moment, I think we'll all be very glad when we no longer have to wear them. I think there is a good place, though, for the clear visors, if that's a possibility as well, for professionals when they're communicating with people with dementia or any other communication difficulties.
Okay, great. Our next question is from Samantha. What about the opposite issue? A dementia patient who has an obsession with toileting, forgetting that they have been, and they have extreme straining, potentially causing hemorrhoid issues. Any best practice tips for managing this?
Again, I completely agree. This is really difficult. And of course, there are some people who have obsessive traits as part of their dementia. And for some, that may manifest itself in in issues around toileting. I think sometimes, again, it's about looking at what some of the underlying issues might be. Is that driven by dementia? Is that driven by anxiety? Is there another comorbid condition that's not being addressed? Is that person experiencing discomfort? Do we need to rule out other medical conditions? But it is really just tipping away gradually at what some of the issues might be. But it's not unusual for people with such severe cases of sort of obsessional toileting that they do have to go into 24-hour care, because it comes too difficult for someone to manage in the environment. But again, there are medications that can be used to look at some of the behavioural and psychological symptoms of dementia. So I think work collaboratively with your mental health team as well, because I think sometimes it's kind of, it feels like it's you or them, and I think it's really important to draw on their experience and expertise to see if there's anything that can be done both practically but also medically to support any changes there as well.
Okay.
Appreciate it's difficult.
Yeah. What evidence do you suggest is required to present to commissioners to review product algorithms?
I think it's very much about looking at, the impact of premature care admission for people with dementia and their family carers. It's also perhaps talking to family carers about their experiences. What is it that would perhaps force them to consider their position of being able to care? Are they all, are they worried about continence? Because I think it's really difficult. There's not lots of quantitative data out there. So we perhaps have to look at some of the qualitative data. But there is some health economic data that looks at what the cost of a person being at home is compared to what the person living in care is. And again, I think there's some really strong cases to look at. Well, actually, yes, this might cost a little bit more in managing their continence aids. However, if you look at the system as a whole, if that person stays at home for another 6 to 12 months, there's a significant cost to the system. And now we're moving towards integrated care systems. I'd like to think we are going to think more laterally rather than very niche about elements of people's care. Although I've worked in health long enough to know that's not going to happen overnight. But yeah, I'd urge you to kind of use what evidence we do have in terms of the costs of long-term care, and of course, what the impact of an inappropriate or an avoidable hospital admission might be on someone with dementia too.
Okay. The next question is from Joanna. How can we help a male service user who urinates in appropriate places, other than regimes, etc.?
Again, I think go back to the case of Jack. Is there a way of accommodating? Is there a particular place they go? Could you use a bucket? Could you use a Jerry, as in the case of Jack? You know, are there other mechanisms? I mean, I was told this story by one chap who was an ex-soldier, and he used to tell me that the reason he thinks he might have to go into the wardrobe was when he was in the block, he used to always pee in the wardrobe because it was too far to go down the corridor to the toilet. So I'm not saying that that's the answer in this situation, but it's about understanding, is there another alternative that might feel familiar to that person? Because we can't always stop it, but I don't know obviously what this particular whether passing urine, but plant pots tend to be a very frequent one. People often pee in plant pots, so you know, can you put a bucket in that corner? But it is, again, very, very difficult. There is no right or wrong answers. It is about being creative and seeing if there is a way to, you know, find a more palatable way, if you like, of letting them perhaps not pee in the toilet, but go somewhere where it's not going to cause too much damage.
Okay. Have you seen an impact on families needing different products due to limited outsourced support carers due to COVID restrictions?
Anecdotally, yes, because of course what a lot of families did as soon as COVID struck was that they were saying, you know, we don't want carers in the house because we're worried about, you know, we want to shield and all the rest of it. So certainly, yes, I've heard anecdotally from people on my caseload that certainly during the first 3 months where they perhaps had been managing with small pads, and then they were then looking at, you know, where could they source pull-ups and things like that, because it was easier for them because they were doing the personal care. So yes, I think COVID has had an impact, but I think that's a result of reduced packages of care as opposed to perhaps a change in the continence needs. But then I would guess you could also then turn it on its head and say, well, if they're more able to manage the needs when they've got the right aids, do they need the package of care in the first place? And some families may say, actually, they may not need as much care if some of those other issues are addressed. Although there are many carers, I'm sure, who are waiting desperately to reinstate a full package of care once they no longer have to shield.
Okay. The next question comes from Ellen. Do you recommend turning the tap on to imitate urinating? And Ellen says that she sees a lot of people do that.
Yeah, people do it. I mean, I don't know what the science is around it. You know, I think throughout my career, we've always had cases where we've kind of done the sound of running water. And I guess, you know, that we've all had situations of stuff where running water has made us sort of think, oh, do we need to go to the bathroom? So I'm sure there are trigger mechanisms there, and it won't do any harm, to be quite frank. So it's if in doubt, have a try. I think, again, because the sound may stimulate a sort of a response that you weren't expecting.
Okay, the next question's from Claire. Any top tips for caring for a patient living with dementia in a ward setting?
Yeah, I think, again, what I would suggest, you know, I've worked in acute and I know continence management is challenging. It's really, really, again, listening to the patient and thinking about what's best. From a dignity perspective, you know, if you're in a 6-bedded bay, if you're asking to go to the toilet and you can actually go to the toilet rather than sit on a commode, that might help situations. It might be about regular prompting. I came across a scenario only a few months ago when visiting the hospital where a gentleman, an elderly gentleman with dementia, was constantly saying, I want to go to the toilet, I want to go to the toilet. And what happened was the member of staff kept coming and saying, well, you've got a catheter. Well, of course, a gentleman who's got cognitive impairment hasn't got a clue what catheter is. Anyway, he kept calling out, and in the end, I had to intervene. I was actually there as a visitor, and I went across to this gentleman and said, do you need to go for a poo? And sorry for the language, but of course that was a language that he would have used rather than saying, do you want to open your bowels? And he went, yes. So of course I went back to the member of staff and said, look, you know, he might have a catheter, but he does want to open his bowels, you know, and take him to the bathroom, which he did, and it was successful. So I think it's, again, it's really difficult when you're in such a busy environment to perhaps engage in those prompts and things like that. But it's really, really important. And also monitoring bowels, because what tends to happen is people who are semi-independent and obviously take themselves to the toilet, the bowels aren't often recorded in the same way that we used to do back in the 19, whenever I qualified. which is a good thing that people are independent. But of course, all those things can sometimes kind of slip under the radar. But it is difficult. And I think sometimes there's a propensity to put people in pads because it's seen as quicker and easier. And in the short term, it might be, but in the longer term, it most certainly isn't, because that has all sorts of ramifications for people going there. But again, prompting, thinking about the familiarity of the toilet, looking at the environment, looking at the signage is really important, because hospitals are very chaotic places that people might not be familiar with. So again, lots of signing and pictorial signs can be really, really helpful.
Okay. And the last question this evening, is there any research that you would love to see in the coming year on continence and dementia?
Oh, good Lord. We could have a whole session just on that, I think. I'd just like to see more time spent on the impact of family carers and the dignity element of people, particularly with advanced dementia, because as I said, it's often assumed they don't know, they're not continent anymore for multiple reasons. But I think for me, looking at the impact, particularly in those early to mid stages where it can affect people's mood and functioning and ability to live as normal a life as they possibly can while they're relatively cognitively able to, I would really welcome that. But I think that there is so little research actually in the grand scheme of things around continence and dementia and managing it, that we certainly need to be shining a light on it and encouraging those kind of studies to be undertaken.
Okay. Right, well, thank you everyone for all of your questions, and Zena for your answers. And this concludes our live training session. Thank you for engaging, and thank you Essity for supporting this event. The certificate link is on the screen now, and you can like our UCCT Facebook page to hear about future events first. So take care everyone, and we hope to see you all again very soon. Thank you.
Thank you.